Buon pomeriggio a tutti e benvenuti al quinto pomeriggio del Cardiocentro del 2026. Benvenuti alle persone in sala, ma anche alle persone connesse in remoto. Il tema di oggi è un tema appunto controverso. Parliamo di dislipidemia e controversie nella prevenzione cardiovascolare. Abbiamo oggi il privilegio di avere due dei più grandi esperti nazionali ma anche internazionali in questo campo scientifico. Inizierei, abbiamo deciso un po' di modificare l'ordine delle apparizioni e vorremmo iniziare prima di tutto con i casi clinici che verranno presentati da Vittorio Beltrani, capo clinica a Mendrisio in cardiologia, e poi dalle due relazioni dei nostri speakers. I think that we will now switch to English, and I will welcome our Vittorio Beltrani, and thank you for being here.
Okay, now it's better. Okay, so almost everybody here knows me. I'm Vittorio Beltrani. I'm a clinical cardiologist working at the spoke center of Cardiocentro in Mendrisio. I'm not an expert in dyslipidemia, and when they told me that I had to present clinical cases about controversy in management of dyslipidemia, I was kind of puzzled. Especially because when I started working in this hospital, managing dyslipidemia looked kind of easy. There were two drugs, statins, ezetimibe. It was easy. And then I was a resident, and it got just slightly more complicated. We had PCSK9 inhibitors, bempedoic acid, but yeah, I mean, 4 drugs, I can manage that. That is easy. Nowadays, things look a little bit more complex. The lipid panel got longer and more complex. We have an incredible amount of new drugs, of molecules. Some are really promising. Some I really don't know anything about it. And every time there's a new paper about lipids and management, it gets even more complicated. So yeah, I'm not an expert. What am I going to talk about? But yeah, but maybe the guidelines will help me. Just a few weeks ago, they published the new American guidelines. So yeah, here, I'm going to read this, and it is going to be easy. Too bad this document is 134 pages long. It has 45 new recommendations, 14 not so easy to read flowcharts. So yeah, that is not going to help you a lot. And well, but maybe I just have to talk in front of my colleagues. Actually, I have to present cases in front of the guy that actually wrote European guidelines. So it's not an easy day for me. I decided not to fake of being an expert, but just to present 2 cases that I saw recently. Actually, I saw these 2 different patients on the same day a few months ago. And yeah, when they told me to present cases about dyslipidemia, my mind went to these 2 patients because they're at the opposite end of the spectrum. And so I'm going to present what they did, and maybe you will give me some insight and I will learn something. The first case is this guy. This guy, super happy. He's a super athlete. He's 36 years old. He is a recently retired F1 and rally champion. He trains like a maniac, at least 3-4 times a day. He does CrossFit. He does a normal cycling tour for him is 100 kilometers. His parameters are perfect, of course, and he has absolutely no symptoms. He's in top physical condition, but since he recently retired, he does not have to do all these physical tests that he had to do because of the federation. So I said, okay, let's do a blood panel. The blood panel was perfect, except for, except for this. High cholesterol, weird. Yeah, his father had an MI when he was 50, but he's obese, he smokes a lot. So why does a patient like this has high cholesterol? Well, maybe he went into retirement, maybe he trained a little bit less, he partied too much champagne, who knows? So for him, not being in top condition is clearly something abnormal. So he spoke with his GP. He really checked his diet even more. He trained even more, if possible. And after 3 months, he checked again the lipid panel. Yeah, even worse. Now we have a problem. He comes to me extremely worried. Doc, what's happening to me? Am I going to die? And I can tell you that the diet was really perfect. It was not some keto, carnivore, weird stuff. The training, of course, was better than 99.9% of the population. So yeah, it's weird. Why does this guy has high cholesterol? So what's next? Yeah, risk assessment. The physical examination was unremarkable. High cholesterol, father had an MI, maybe there's something more. The Dutch criteria, possible FH. What should I do next? Well, I just asked for the blood panel of the family. The father, after the MI and secondary prevention, is taking atorvastatin and ezetimibe. The LDL is not on target, but slightly above, so nothing special. The mother takes rosuvastatin in primary prevention. Cholesterol was okay. And he has a sister, younger, doesn't take anything. The blood panel, to me, is unremarkable. So what's next? Should I try to risk stratify this patient with the score 2, with the AGLA score? Yes, maybe, but this guy is 36. He is a top athlete. To be honest, I'm not sure that this score works for this kind of patient. So, okay, maybe some more variables. I checked the ApoB, APO1 ratio, it was okay. The lipoprotein small a also was okay. Should I include the lipoprotein to the score 2 to try to increase the specificity and sensibility of this score? I don't know, to be honest. I still had I was still thinking that the score 2 was not was correct for this patient. I mean, how many athletes were used to validate this score? So what should I do now? Should I do a genetic testing? Should I do a CAC score, a photon counting CT? Should I do a functional test? Well, if I look at the advertisement in my Twitter account, probably a CAC score. Every day I get this, and I never use it. I never use it because most of the time when I have to do a CT, it's a coronary angio CT, so I really need to exclude or check the coronary arteries of a patient. And I found that for most of the patients that I normally see in my hospital, the CAC score only slightly modifies the score 2. So I don't know. I don't use it for this. Also, we know it is influenced by statin use. It is influenced by sports. There are Asian registry with older athletes doing endurance sports that have high CAC score, but they don't have events. So what's the use for this? And we know that there are soft plaque with very low Agatston score that can rupture and cause ischemia. So having a CAC score 0 is not really a protection. So what did I do? I'm not this old, but I just spoke with him. I explained the relative risk reduction of taking a statin, the risk of having high cholesterol. He thought about it for a month. And after a month, he called me and said, okay, doc, I'm ready. And I started rosuvastatin and ezetimibe. After that, I told him that I will check again the lipid panel in 3 months. Maybe it's too long. Maybe it's not soon enough. To be honest, I think that if I check it too early, the patient, they try to cheat a little bit. They started taking something for the cholesterol, so they also start to eat a little bit better. Maybe they exercise. I do the blood panel in a month, and it is okay. I think the dosage of statin is correct. And then they stopped doing sports. They started eating bad again, and the LDL goes up, and it is not treated. What about side effects? Well, if it has a clinical side effects, it's going to tell me. Otherwise, should I be concerned by a subclinical increase in liver test? I don't know. I never had really problems in patients that didn't have any symptoms and they were not high risk. What about the fact that they started a pill in a 36-year-old world-famous athlete? Is it too soon? Well, maybe, but we know about the lifetime exposure of LDL. We know that the higher of LDL and the longer the exposure, the higher the number of events. And we know from trials made on children with FH that the early lowering of LDL really changes the history of these patients, lowering the number of events. So lower and earlier should be best. This was my first patient. I will now start with the second one that, as I said, completely different side of the spectrum. This is blood panel, lipid test. He's already on combination therapy. We can see that triglycerides are really high. So yeah, easy win, probably lifestyle modification, better diet, maybe fibrates. This is going to be easy. Well, this patient is 73. He has a prior failed kidney transplant. Now he's on dialysis 3 times a week. He has AFib and it's not on oral anticoagulation. He had the steroid-induced diabetes with a difficult control because of the failed kidney transplant. And I met him here for 3 vessels coronary disease. He had angina. We started with medication and it went really good, really well for a couple of months. After that, he casually told me that he was consuming 1 bottle of nitroglycerin per week. So I said, okay, let's do a CTO. And I don't know if the mouse works. So yeah, there was a very complex procedure of retrograde CTO that went really well. And after that, I could remove all the anti-anginal medication. But it is not over for this patient because he also has lung cancer with multiple metastases. He had a lot of chemotherapy. Now the disease is stable, but it's not cured, of course. And there was another thing missing. Sorry. He also has he also had a perforated diverticulum, and now he has a colostomy. So this patient is really, really sick. Not an easy win. So what did I do? Immunosuppressed patients, dialysis, 3-vessel disease, high triglyceride. Well, we know that the problem of dosing the LDL in patients with high triglyceride. We know about the lack of benefit of statin in patients on dialysis. I never started with this patient, but if they already have it, I leave it. How to manage this patient? PCSK9 inhibitors, I don't know. Fenofibrate, to my knowledge, are contraindicated in dialysis. Icosapentaethyl, maybe. But to be honest, I thought about this publication, this paper that we published last year. It is about deprescribing heart failure medication in the elderly. So nothing related to dyslipidemia, but there is this figure that I always think about when I treat this kind of patient, very old. This patient has so many competing risks that, to be honest, I don't think that the prognosis of this patient can be influenced by the lipid control. He has already so many diseases that I think that it was for me, it was the decision was not to give him another one. So I simply never checked the lipid test again. And these were my two clinical cases.
Thank you very much, Vittorio, for these beautiful cases. There are already questions about these two cases.
I can start the one, if I can start with that question.
Yeah.
So it's very interesting, your first case, the young athlete, apparently very healthy. So in the first evaluation, did you ask also for high sensitive PCR?
No.
How could be considered the value of a high PCR and maybe how this can change the management? This is one aspect. And the other one, if I can, is about family history. Two parents already treated for dyslipidemia. Any previous CV events before? And for these young subjects, what are the current indication for genetic testing for familial hypercholesterolemia? I take the opportunity also maybe to ask them for their opinion.
Of course, I'm not going to give you the answer of what is correct. I'm going to tell, because they are the experts. I'm just going to tell you what they normally do. For high sensitivity CPR, yes, there is a possibility. You can also include it in some scores to, like I said, like I showed with the CAC score, but to be honest, I never do it. Maybe it's wrong, but it's not something that I normally do. And about the history of the family, no prior events. That was actually the reason why I decided not to do a genetic testing, because I thought that the probability of having a homozygote FH was really, really too low with this history. And the incidence of heterozygote FH is really quite high. And I'm going to follow the lipid test. And if your status is not enough, I'm going to upgrade. But starting really too soon with everything, I don't see the reason. If you follow the patient, you can do step by step. That is what I normally do. Of course, this was kind of a special case because we're talking about a very elite athlete, not a normal 50 years old patient. But yeah, that is what I've done. Maybe it's wrong.
You heard me? Yes. A question about the first case, young athletes in primary prevention. Do you ever give to your patient a target, a cholesterol LDL target, first? And second, if you make a CAC score and you find a 0 score, do you continue with your statins, or will the CAC score 0 say it's no problem with your?
Yeah. So the target for the first patient, I don't know how to consider it. I mean, if we do the score 2, we might have a probability, and it might be intermediate. So we can say 2.6, or that it depends. But for this patient, I normally explain to them that the lower the better. But if the first blood test, the LDL is already in the normal range, might be good enough. For the 0 CAC score, as I said, I don't do it, but it happens a lot that you do a coronary CT because you have a positive stress test and you really do think that the patient is at high risk. And so you really want to see his coronary angiogram. And when I ask for a photon counting CT, I always ask just to tell me the Agassiz score. Sometimes it happens that is 0. But I don't know what to do then with the statin. It is also true that the coronary might be okay, but the carotid might not. And if the score gives a very high stratification, I normally leave it.
Okay.
too many errors, so they need time.
Very nice.
Thank you very much.
Thank you.
Thank you, Vittorio. This was really a good start, I would say. So good afternoon, everybody, also from my side, and also good afternoon to the more than 77 colleagues that are remotely connected. So this is a really good event, also very well attended by our colleagues. So it's my pleasure now to introduce Dr. Konstantinos Koskinas from Inselspital Bern. It's a real great pleasure to have him today with us. Dr. Koskinas has made a major contribution to the field of preventive cardiology, particularly dyslipidemia management, cardiovascular risk reduction, and he's deeply involved in guidelines development. So take the opportunity really to ask questions to our experts today. It's a really great opportunity.
So thank you so much for this nice introduction, for the opportunity to be here. We love being in Lugano every time we have the chance. The cases were really excellent, and they highlight, if I can say in advance, that there's not always a correct or an incorrect approach. So many cases are in the gray zone, and you cannot dogmatically treat a case, a patient, an individual, as if there was really one single correct answer or treatment. I'll try to touch upon the cases as I show my presentation. So the goal was to address some rather controversial aspects of lipid management or risk assessment. So I chose exactly the field of primary prevention, because I think that all of us are more or less more familiar with the concept that intensive treatment is indicated in patients who already have had a disease, heart attack, but it's less so in primary prevention. And the second one, briefly, we'll touch upon LPA, which is also something that is causing interest lately. So the concept is clear. We used to speak about the theory that lower is better. Now we have evidence from really millions of people or patients or individuals in both genetic studies, observational studies, interventional studies with lipid-lowering agents, and they all have shown more or less the same thing, that if you achieve a lower LDL, then the prognosis of our patient is better. And obviously, the longer person is exposed to lower LDL, either through drugs or genetically, the better is the prognosis, or the stronger is this correlation. We have to say, an important point, what the studies have shown is the average of patients. Either we speak of a study of a few hundred or of a million patients, we know from the results, the summary, what happens on average. We don't know what will happen in each individual person. This is something we always need to keep in mind. Now, we know, as I mentioned, that statins have a great record in trials of patients who already have disease and secondary prevention. We often have the question from physicians, from patients, do I really need to take a statin? I haven't had a clinical problem so far. What's the evidence? What's the indication? Just as a summary, we have had also RCTs in primary prevention starting from some decades ago. For example, the Jupiter trial was one of the first positive trials in the primary prevention field with high-dose rosuvastatin. And if we look at the meta-analysis, the classical CT meta-analysis that looked at many trials and hundreds of thousands of patients, and they divided them into those who did or did not have known vascular disease or primary or secondary prevention, you can see that the risk estimates are very similar. And actually, the risk reduction on the top in primary prevention is numerically at least even larger than in secondary prevention, which means simply that either a patient has or does not have a known disease, then the reduction, the relative reduction of risk is the same per 1 millimole per liter of reduction of LDL. But of course, then the absolute reduction is not the same because the baseline risk is not the same. So if you have a reduction of 30%, it's not the same in a person who has already had a heart attack versus a person who has zero risk factors other than a slightly or moderately elevated LDL. This is something also we need to keep in mind and discuss with our patients. What about older people? Also touching upon the example that you showed. We do have, first of all, RCT evidence in sub-analysis looking at patients who were older than 70, and they more or less showed consistent results, although the magnitude of benefit was smaller in those who were older than 70. And this was also a signal from the CTT meta-analysis. You can see they're up to a certain age. We do continue to have benefit, but this seems to be smaller than in younger people, which also makes sense because, of course, of the competing risk factors. So irrespective of age, but there's less direct evidence for those older than 75. This is what the RCT evidence has shown. And this was also more or less confirmed in observational studies, although we do need to be a bit cautious with these observational studies. They cannot show causality. But again, for example, this was one large registry. It showed in many thousands of patients that who newly initiated statins during the study period, and with an extensive follow-up of almost 7 years, there was an association of initiating statin in older people after 75 with reduced mortality. Again, it's an association. We cannot speak about causality here. And also here you can see the graphs of these associations across different age groups. And also we know from studies, also Swiss studies, that discontinuing a statin is associated with an increased risk of recurrent events. This was one of the largest French studies some years ago. It confirmed this. So if a person does have indication to receive a statin, then stopping this is associated with a worse outcome. So we do have evidence from statins. We also have the newer drugs. We have the injectable drugs in the last years. It's many years now. We can't no longer call them new drugs. They are approved also for clinical use for almost a decade now. And recently, in the last months, we had some new evidence for these monoclonal antibodies in the context of primary prevention. It was the Vesalius trial. You can see on the very right side what was shown previously from the classical large trials, Fourier Odyssey outcomes. This was high-risk secondary prevention, so patients who already had not only atherosclerosis, but also heart events. For example, they have had an MI. You can see the known results with a reduction in risk, 15% relative risk reduction. Now, this new trial, the Vesalius trial, looked at patients at a relatively lower spectrum of risk, either primary prevention or secondary prevention, but without MAs, without a stroke or MI, one-to-one randomization to either volocumab or placebo on top of statin. And it was also a positive trial. And interestingly, the relative risk reduction was larger than previously in the Fourier trial. This may have to do also with a longer follow-up in this trial, more than 4 years. It was only 2.5 years in the previous trials. And if we look at the subgroup of this trial, which was really only primary prevention, they were all patients with diabetes, but with no known atherosclerotic disease. This sub-analysis, including more than 3,000 patients, was also positive, showing almost or more than 30% reduction of 3 or 4-point MACE, and also a reduction in all-cause and CV mortality. So we do have evidence of benefit with statins some decades ago, and also now with the new drugs. This leads, of course, to the new recommendations, and we start, as always, with risk assessment. An excellent point. Can we use the SCORE2 in a person who's 36? Actually not. It was derived and validated in people between 40 and 90 for the SCORE2-OP, so it doesn't make sense to use it. But we also have to say that we should not use it in some patients who we know are at high risk. For example, if you have known disease, it doesn't make sense to use SCORE2 or AGLA. If you have a possible FH, this automatically makes you a high-risk person. You don't have to look at the SCORE2 or the AGLA at all. We know it will underestimate it, so we shouldn't use it at all. These are the categories, primary and secondary prevention, and you can see here that very high risk includes either patients with known disease or patients who don't have known disease but have advanced risk factors, for example, a very high SCORE2, patients with CKD, kidney disease, many patients with diabetes and other comorbidities, and so on and so forth. And the concept is clear. When should we treat in primary prevention? It cannot rely only on the LDL level. So if someone asks you, doctor, I have an LDL of 3.8 millimoles, should I take a statin? The only correct answer is, I don't know, unless you tell me the rest of the risk profile. This is the only way we can be correct. And then, as you can see, in red color, there's a strong indication to start a drug. The yellow color means that you can consider adding a drug. And the green color is that lifestyle is enough. And as you move to higher LDL levels in combination with higher risk, then it becomes indicated to consider a treatment, a statin treatment. So in the case of the young athlete, he does have a quite elevated LDL. This makes him a person at high risk, at least because only of the LDL. So he essentially does have an indication for a drug. But then begins the great discussion. And as I mentioned, the trials show the benefit on average. And we also have studies showing that not all people who have an LDL of 5 or 6 or 7 will develop atherosclerosis after 5 or 10 or even 30 years. We see people with this profile who never have anything. We do a CT or invasive angio, and they have completely normal vessels. This is something we need to keep in mind. So we enter a discussion, we explain, as you very correctly did, what would be the potential benefit, what are the potential side effects, and then together with our patient, we can decide. And using imaging can help us. The CAC score may not be the best, as you very correctly mentioned in this person, because if you have a young person with very high LDL, if at all he has the sclerosis, it will be a soft plaque. The calcium score will be 0. You will be incorrectly reassured, but this does not make that the person does not have atherosclerosis. It might be reasonable, also maybe someone would say it's exaggerated, to do a CT angiography to see exactly if there's plaque, not calcium per se. I will show also a slide afterwards on that. So score 2 is simple. We can all calculate it in our everyday practice, but having a simple test comes at the cost that it's not very precise, of course. The same applies to the AGLA score. The same applies to the American scores, or also the newer ones that they introduced some weeks ago. It gives you a good first impression, a screening, but you cannot rely only on the score 2. It does not tell 100% of the truth. This is inevitable with any such simplified tool. We have to say, in defense of the score 2, it was developed based on very large cohorts, European cohorts, which is at variance with any other risk assessment tool, also including the American tool. But it's not perfect. Studies have shown that, try to validate it. And here you can see one of these studies. If you see at the diagonal line, the black line, it shows the correlation of what you predict based on score 2 on the left or score 2OP for older people on the right, and what you really observe in clinical reality. If it was a perfect score, the blue and red line would fall on the black line. This is not true, obviously, which simply means that the score 2 and also any other tool underestimate risk. So what you expect is much less than what you actually see. So even if you do the score 2, probably the risk may be higher. But again, this is not a cookbook. In some people, the real risk may be lower than you can calculate based on the score 2 or score 2OP. And this was the conclusion of the study. What about incorporating other variables? Score 2 is quite simplistic. One could think about adding other clinical or lab variables. Indeed, they've shown that they improve the performance of the score 2. Some of them include the BMI, the CAC, the carotid stenosis, CRP, LPA, and proBNP. And this was also the conclusion of that paper and also of many similar papers that followed. So because we realize and we all appreciate that the score 2 and any other tool, also the AGLA, is not perfect, we also now in the new guidelines and the update recommend that we keep into accounting, into consideration also what we call the risk modifiers to give us a somehow clearer, more correct estimation of the risk. And this can be either imaging or clinical or biomarkers. And you see here an extensive list, and we know also empirically, also from our everyday practice, you may have a person who has obesity, who has a positive family history, women with preeclampsia. This is not captured in score 2. So if you only do this simplistic calculation, you will miss a lot of valuable information. The same holds true for these biomarkers. We know, for example, as you mentioned, for CRP, for inflammation, many studies have shown that you can predict risk using this simple biomarker. One of the most recent and largest analysis was an American study by Paul Röttger. He showed in almost 30,000 women, initially healthy women with a very long follow-up of 30 years, that both CRP and LPA at a single time point predicted risk 30 years later, which is quite amazing, I think. And also, it's also the combination. If you have more biomarkers that are elevated, you can be better at predicting or identifying people or persons who are at elevated risk of future long-term events. The same holds true for imaging. We know that both carotid plaques and calcium score in this case associate with worse prognosis. This was shown in many CT and ultrasound analysis. We know that at very high calcium score levels, you can have, even if you're in the primary prevention context, you can have a risk that's similar to a person who has already had a heart attack. So it makes sense to treat this person more aggressively, more intensively. And this is also the comparison between primary prevention and patients who already had an event, such as in the Fourier trial. But as I mentioned, we need to keep in mind that calcium is only a late manifestation of advanced atherosclerosis. It occurs only when enough plaque has accumulated, and possibly you've already had plaque rupture and plaque healing. And if you look at the mean age, when you transition from 0 to above 0, it's on average 53, but you've already had many years of exposure to high LDL. And if you look at the age of transition to above 100 of a calcium score, which is also in the American guidelines, a value threshold to initiate treatment, for example, it happens at 67 years. At this age, many people have already had the first event. So not looking at calcium only, if possible, especially in younger people who may have soft lipid-rich plaques, not calcified plaques, and the presence of non-calcified, even non-obstructive atherosclerosis also associates with future risk of MI or even death. And of course, nowadays with CT, you can see not only the volume of plaques, but also the composition. So you have the so-called high-risk plaques. And if you have such plaques, then you know that your future risk is higher than if you don't have such high-risk plaques. What about clinical modifiers? You did show some of them. One of them is, for example, obesity. We know it's a pandemic. We know that it's rising dramatically over the past decades. We know that high BMI associates with increased mortality. And we know that people who have obesity die predominantly because of heart and vessel diseases, not because of other complications of obesity. And this is why we as cardiologists should also keep this in mind. We know that obesity affects many aspects of the heart and the vessels, not only atherosclerosis, but also heart failure, the vessels, arrhythmias. And one would expect that it would lead to deposition of lipids in the arteries. But as you can see, the association is even stronger for heart failure, for example. This is why you are also publishing next year this first guideline. So let's take a look at an example exactly to show how we should not be fixed to numbers and categories and boxes. You can see a person, a young person. You can see the lipid levels, and otherwise normal weight, normal LPA, and no atherosclerosis on screening. The score 2 shows a moderate risk. On the other hand, you have a similar person in terms of the key score 2 defining variables, but on top of that, you have a high BMI, high LPA, and you already have a plaque, non-obstructive plaque on CTA. If you only look at the score 2, they will be the same. it doesn't make much sense, I think. I think we all agree that they should not be treated the same, and this is why also according to our recent European and also the American very recent guidelines, we can reclassify, we can consider this person as having a higher risk than we would assume only based on the score 2, and this has very clear consequences. If we didn't consider the risk enhancers, it would be a moderate risk person, so the drug treatment yellow, you may or may not consider it. If we reclassify, he becomes a high-risk person, so he has a stronger indication for starting treatment. You can also see it in this recommendation table. Should be considered if we ignore the risk-enhancing factors, is recommended if we take them into account. And the treatment goals, moderate risk, below 2.6 millimoles, if we don't consider the presence of plaque, obesity, or LPA, even lower if we take them into account, below 1.8. And we know that currently, with a combination of drugs, we can lower LDL levels dramatically. So I think that my comment also regarding the cases is that we should not be fixed on a single algorithm. This is the case for any available algorithm. We should use our clinical judgment. Guidelines are not cookbooks. We should decide based on our clinical judgment, discuss with the patient, and see what we can offer, balancing the benefits versus possible side effects. If we want to postpone treatment in this young person, in this young athlete, we can do it. It is reasonable to check perhaps for those sclerosis, and this will be reassuring if we want to have a more conservative approach. About your patient who was multimorbid, I think we should also be realistic and pragmatic. I also agree with you that atherosclerosis is not the primary risk factor in this case. We have every right to be more conservative than we indicate in a box of recommendations and guidelines. And very lastly, very briefly now, what about LPA? We know in the last years that it is gaining importance. It has prothrogenic and prothrombotic effects. It is common, 20%, so quite a lot of us in this room have elevated LPA in the population. It is associated with risk independently of LDL, and we know that the higher the LPA levels, the higher the additional risk. Previously, 6 years ago, we recommended screening in order to capture those with very high LPA. What we recommend now is, again, universal screening, but also to identify those with moderately elevated LPA, because also at lower levels, the risk begins to increase. But we need to keep in mind, high LPA is a risk multiplier. If you have, because we also receive phone calls and emails and letters, if you have a young person, 0 risk factors, very low risk, and you have an LPA which increases the absolute risk by 30%, the absolute risk will remain very low despite the LPA. So it's not the same approach independently of the overall risk profile. And here's an example. Also to the question, why should I screen if I cannot lower it currently? You can address the other risk factors. For example, here are 2 examples. On the very left, you can see a person who has very high LPA, but otherwise very well-controlled risk factors. On the very right, you can see a person who has poorly controlled diabetes, hypertension, obesity, and has a genetically low LPA. The prognosis in the person with high LPA is better than the one on the right, and this shows you exactly why it matters to address the overall risk profile, not necessarily focus on LPA per se. In a year from today, we may or may not be able to lower it with the new drugs, but even independently of that, even if the trials are negative, it does have value as one of the many additional risk-enhancing factors, and this is what you can achieve. Some of the drugs also lower LPA, the PCSK9 inhibitors by 25%, but it's not relevant if you have extremely elevated LPA levels, and these are the experimental drugs that are currently developed. In the next months or in the next couple of years, we will have results of large CVOTs for all of these drugs. So I hope we could address some of these controversial issues. So I want to thank you very much for the very, very interesting cases, controversial cases. Again, there's no single correct approach, especially in the so-called primary prevention, as opposed to a patient who already has had a heart attack where the indication is clear. we should use our clinical judgment, discuss with our patients, use as many tools as possible to estimate risk and then decide accordingly. Thank you very much.
Thank you very much for this really great, extensive, and up-to-date overview. You addressed many, many issues, so really thank you very much. Is there any question from the audience?
Thank you, Kostas. Excellent. It will be so difficult to speak after you. I think you really convincingly show that there are risk modifiers and that maybe imaging could be very useful. Now cardiac CT, particularly when it's a little bit more costly, it's a little bit more invasive than, for example, carotid duplex. By any chance, I mean, for opportunistic screening, is this the same value, or are there studies? I mean, you showed it in one study. Is the predictive value a little bit better when you do cardiac CT with angiogram?
So that's a great point. Again, we need to take into account the evidence, but also practical issues, availability of tests. There seems to be a little bit of more of evidence for CT scanning. The reason why it seems to be more prominently recommended in the guidelines is because we now upgraded it. It was previously a 2B recommendation, now it became 2A. For many years, screening with simple ultrasound, carotids, femoral, they already had a class 2A recommendation. So whatever any clinician can do in his or her practice is valuable to screen, and obviously if it's zero radiation, if it's much less cost, it can be valuable. We need to keep in mind that atherosclerosis is a systemic disease. If you have atherosclerosis in one artery, it's likely, but also you cannot, of course, be sure that you also have atherosclerosis in other territories. You cannot, of course, be 100% sure of that, but it does help. We are not recommending, obviously, that everyone receives screening. It's not practical. And this gives me the opportunity also to say that we can only recommend what has been shown in studies. We cannot create evidence. We cannot come up with evidence that doesn't exist. And in some areas, there will never be studies that will address some questions. We need to simplify. We need to come up with documents that can be clinically useful. Biology is much more complex than having 3 or 4 boxes of risk categories. It's much more complicated than one single threshold to decide whether to treat or not. Somehow we need to be oriented, but then again, clinical judgment always comes in play and can change our decisions. Right?
Thank you for the beautiful presentation. I do have 1 or 2 questions about lipoprotein small a. The first one is, I studied that you should test it only once, and then there are some people say maybe twice in women during the lifetime. And the second question is, I read about the possible increase in lipoprotein A with statins. Should we be concerned?
Excellent points, both of them. Thank you. So for women, indeed, after menopause, you can have a small increase. And it makes sense to measure again if a woman has a pre-menopause value that's just below what we call the threshold that defines high risk, which is around 50 milligrams or 110 nanomoles. The majority of women will have very low LPA in the range of 7 or 10 or 20. So it does not make any sense to repeat the measurement in this context. And the second one about statins, they seem to have an either neutral or small increasing effect. But as always, one needs to balance the benefits versus the risks. It's the same with statins increasing glycated hemoglobin and increasing the diabetes risk. But what you benefit from the large reduction of LDL is much greater than the small increase in statins. So it should not be a reason not to start a statin if you have an indication to do so because of the high LPA and because the additional small increase will not be important enough to meaningfully affect the overall risk or the trajectory. Right?
Thank you very much for the great presentation. I have a small clinical question. A patient, again, primary prevention over 40 years, 43 years with 5.3 LDL. who is in perfect conditions, is very sportive, is slim, diet and everything, with who I have started this, and has a familiarity, quite strong familiarity with who I have, for who I have started a statin, which combined statin, which has brought up to 2.6. The target, according to you, should be 1.8. He's, as I said, very active physically, and I do care that he doesn't stop any physical activity due to the fact that I have loaded. Or you would advise to see about the subclinical atherosclerosis, the other modifiers? This is the first question. The second, in fact, the first case of Beltrani was, to my opinion, you underline when it's more than 4.9 for sure, even if it's under 40 years, due to the big studies, epidemiological studies, I think we should treat. So it's high risk, though that has not reached 40 years. So your comment. And the third about the HS PCR, about canakinumab, taking the results of Cantus, the study of Riedke, with not lowering the all-cause mortality just by a single endpoint, but all the 3 and 5 MACEs lowering in patients with infarction with high HS PCR. What do you think is the future?
Great questions, all of them. Starting with the last one, I mean, we know that canakinumab, we had some issues, some safety issues, some infections. It is a potential concern with all these anti-inflammatory drugs, and 3 VOTs are now underway with newer agents. I think we should wait for those results before we can decide if they're meaningful or not. We have had some results with colchicine, some conflicting results, positive versus negative. They have a rather low indication currently, but I think overall the field of atherosclerosis is very promising, but we need to find drugs that are really effective and also well tolerated and safe before we can proceed. Then we also will have the question, what should we first give? Is it pragmatic to treat a person with an injection for LDL, an injection for a CRP, an injection for triglycerides? I think we need more data, and we need to prioritize at some point. We can have offering all these treatments to anyone. Injection for obesity also. The other issue was about the case of the young person. Again, we need to be pragmatic. I would not increase. In fact, I rarely increase statins up to the highest dose because I don't want for this small additional LDL reduction to risk muscular side effects. If we want to achieve better results, we should consider a combination, lower dose statin plus ezetimibe, or now the other oral drug, bempedoic acid. But again, as a general comment, I fully support what we publish in our guidelines, but at the same time, I'm not a big fan of numbers because they are not magical numbers. We need to understand that they are partly artificial cutoffs. We know from many studies that the largest effect of lowering LDL comes from lowering LDL from very high to moderately high, also with mortality benefit. And then you have an additional, rather modest increase when you come from 2 to 1.4. It is important, significant statistically and biologically, but we need to have the big picture in mind, especially if we talk about young people. We need to balance if you start a statin at a very young age in a person who doesn't have a very strong indication, you risk bad or suboptimal adherence. You want to have the person on the right path to prevent the long-term complications. So it needs to be an individual decision. It takes a lot of discussion with the patient. And the third, the case, your second question, indeed, according to all guidelines, not just the European ones, the person does have an indication for statin. But again, we need to respect if a very fit person doesn't want to start with 36, we cannot. If we cannot convince the person, we should at least try to have a regular follow-up and do screening to somehow reassure us that we're not missing on already established disease. It can be reassuring if the vessels are clear to postpone a little bit since the person that absolutely does not want to start a treatment at the age of 36.
I have also a question waiting for the new obesity guidelines. So, as you said, a substantial proportion of our patients are obese. And we know that some of these patients are suitable for obesity drugs, GLP-1 receptor agonists. So when we do some lifestyle advices for our category of patients, should we consider implementation or obesity drugs already? And are these drugs considered some risk modulator in the assessment of the cardiovascular risk?
That's a huge discussion. I would prefer to not discuss it for half an hour because Matthias, I'm looking forward to his discussion. Very briefly, they currently have a class 2A recommendation in our chronic coronary syndromes guideline. We know that they have what we can call pleiotropic effects. You can lose weight, but you have benefits completely independent of the weight loss. But on the other hand, again, I mean, with LDL, you can achieve very little, as you showed in your case, with lifestyle only. That's true. We know it, as opposed to triglycerides. With body weight, if you invest, then it obviously can dramatically change the body composition and all the cardiometabolic consequences of being overweight or obese. So I think that as beyond the few thousands of patients that we look in trials, looking at the big picture, I think that the communities, the population can benefit by adopting a different lifestyle than we currently have in Western countries. We will benefit a lot with much lower cost. But if you have a person where you cannot implement these changes, they are an option, and they have shown clinical benefit to some extent. Yeah.
Any other question? No.
Ecco, volevo solo ricordare che abbiamo più di 80 partecipanti in remoto e avete la possibilità di porre le vostre questioni nella chat. Ne abbiamo dimenticata uno, che è stata fatta da Marco Peronti a Vittorio. Hi Vittorio, thank you for your beautiful presentation. Do you think for the first case that you present that could be useful dosing the oxidate LDL?
There have been some hypotheses, but it hasn't really been proven that it brings a lot sub-fractions of LDL, oxidated LDL. We know the biology. If it's oxidated, it's more deleterious for the sclerosis, but in clinical reality, it would not really change the decision-making, I think.
Thank you very much. And it's now my great pleasure to introduce your second speaker, Professor Matthias Willem from Bern. It's not the first time it's come here in Lugano. Professor Willem is highly respected cardiology and an internationally recognized expert in cardiovascular prevention, sports cardiology, and rehabilitation. Notably, he is currently chairing the upcoming guidelines on cardiovascular rehabilitation, which will be officially presented and released this August during the ESC in Munich. And today he will share with us his perspective of Dislipidemie and cardiovascular prevention. Thank you very much for being with us today, and please.
Thank you very much. Grazie mille for having me here a second time. I was given a very difficult task to speak after Kostas, and I was also told to make it a little bit provocative and to show this controversy. So I said, okay, lipids, but how much bang for the buck? This is a very impressive achievement of cardiology, also of the European Society of Cardiology, because at an EU level, they could really lobby for a safe hearts plan. And you find the words prevention, also including rehabilitation here. And one of the flagship initiatives is a lifelong, personalized and digital enabled prevention. Great words, but remember, personalized. And last time, maybe you can remember this, I showed this picture, this personalized comes from cancer medicine. It's 15 years ago that medicine should be predictive, personalized, preventive, and participatory. And these are more more holistic approaches to disease that also enable then prevention. And of course, we already have implemented this in our guidelines. We have defined different patient populations or individuals that are apparently healthy, where we can do prevention, where we can do prediction. Kostas alluded a lot on this, where we can also let them participate by informed discussion, and then the treatment should be personalized. The opposite thing of this is the polypill, because this is definitely not personalized, and it works. You need a high number needed to treat. I would like to focus a little bit in my talk also on the number needed to treat. But if you give a fixed combination in the prevention of atherosclerosis disease, you really reduce mortality, and you reduce the blood pressure mainly, and you also reduce the LDL. And the question is, what works here? And it's definitely not personalized. So my question for the talk is, what violin do you play, LDL cholesterol? How important you are really? And of course, Kostas shows this, and this looks so convincing. So we come from here and we go all down here, but this is relative risk. And maybe some word on Mendelian randomization in the context of individual level treatment responses. Also, Kostas mentioned this. These are estimates for population level average causal effects. But of course, we are interested in individual level treatment responses. A patient sits in front of us and we need to counsel him or her. And we know that there's a high heterogeneity on LDL treatment effects. Then, of course, there is a gene environment equivalence assumption. So not every individual is exposed to the same exposome. And then there is a linkage disequilibrium and a pleiotropy. So we have different genetic variants. They may all have an impact on LDL, but maybe also on obesity. Then there are confounders, and these really get mixed up. So it's a little bit more complicated than Mendelian randomization tells us. Now, if you look at the population attributable risk fraction of large populations from high, middle, and low income countries, then of course, when our endpoint is myocardial infarction, lipids play a major role. But if we look, for example, at stroke, then it's among others. And of course, hypertension plays a major role. And if we look for all-cause death, or if we look for cardiovascular death, then we see that among others, the lipids range quite at a lower end. And there is education, tobacco use, poor diet, hypertension, household pollution. So there are other factors that are important. And of course, if we speak of reducing the burden of disease nowadays, we also have to take the lifespan and the health span into account. We create with modern medicine people that live quite long, but they live for an average of 10 years with the disease. This is low quality of life, and this is expensive healthcare system. And this has increased over the last 20 years. And if we look at the DALIs, for example, and we look at risk attributable burden of 88 risk factors, we see the same pattern. We see that the LDL cholesterol, whether you look at Central Europe and Asia, or you look at high-income countries or Western Europe countries, they do not rank among the highest relevant. But we always see blood pressure and smoking. And I think it's important to keep this in mind. And then there are different ways of looking at all these studies. And this one is published in JAMA Internal Medicine. And they only looked for the real endpoints that are not prone to subjective assessment. So mortality, myocardial infarction, and stroke. And they highlighted again the important difference between relative risk reduction and absolute risk reduction. Of course, these were mixed trials, primary prevention, secondary prevention, and also combined. But just to give some numbers, to really reduce mortality, you have to treat 125 individuals for about 4.4 years to prevent one death. Just let think this in. And also interested in this analysis, there was no really a clear sign that the amount of lowering was really relevant. So some associations were found between the magnitude of LDL reduction and the size of absolute treatment effects, but this was only shown in stroke, not for all-cause mortality and not for death. So what we've seen from Mendelian randomization studies and also randomized trials, when we look at this meta-analysis, this could not be replicated. Now, just to give you a comparison, you all know the SPRINT trial. And the SPRINT trial had the goal to lower the blood pressure, and it was compared an intensive group. The goal was to lower it lower than 120, and a moderate group lower than 140. And they achieved 122 versus 135. So the absolute difference was 13 millimeters of mercury. And just look at the overall effect on mortality, 52 to treat for 3 years. Just the comparison what you can achieve if you lower the blood pressure in comparison what you achieve when you lower the LDL cholesterol. And also this topic we have discussed, and I think you know them all. This is a 61-year-old woman. She has a pathogenic variant of her LDL receptor. She has an LDL of 10.2, so a clear familial hypercholesteremia, no statin at all. And these are coronaries. And as Kostas nicely pointed out, it's not only about the calcium, but it's so important also to do the angiogram. But this lady has no soft plugs, no nothing. Interestingly, and let's focus on this for the next time, she has a low lipoprotein little a and also a very low high sensitive CRP. I think it's very important. And the take home message was heterogeneous FH. Can we have absence of atherosclerosis despite lifelong elevated LDL levels? And if we look at some studies, at the age of 47, 45 have no calcium. But what Kostas mentioned nicely, this was only calcium. They were quite young, so they might have had other plaques, but quite a large proportion without obvious atherosclerotic disease in a population of well-defined FH. And another publication, this was only the absence of clinical atherosclerotic cardiovascular disease, so they might have had plaques, but this was not shown clinical. And interestingly, this was at least 62% at the age of 65 plus. And if we look at the associations or that were shown, female, zero mutation, hypertension, HDL was protective, and LP(a). So there are risk populations. And there are several studies, I do not want to go into detail, that try to find the difference in familial hypercholesteremia, the event-free group, versus the ones that have an event compared to controls. And what always pops out that it's not only the lipid metabolism, but that it's always also the immune system. It's about inflammation response. It seems to play a major role. And I would like to come now to inflammation and atherosclerotic cardiovascular disease. We already discussed it, and this is a nice, large observational study of nearly 450,000 individuals. They were followed for nearly 14 years. And when you see here, the high-sensitive CRP ranked above several traditional risk factors, and you see the same pattern. Of course, age, of course, sex, smoking, and blood pressure very high, but then high-sensitive CRP and LDL cholesterol only here. And high-sensitive CRP in this group has also an additional value on the score 2 with the net reclassification of at least 14%, but it highlights the importance of high-sensitive CRP. And you all know this evolvement from endothelial dysfunction to plaque rupture, and we already discussed it a little bit. And I think it's so important to recognize smoking and hypertension are really clear, have a causal effect to cause
endothelial dysfunction. But there are interesting findings. For example, a cohort of children with familial hypercholesterolemia, and their Lp(a), but not LDL, was associated with the development of endothelial dysfunction. And in some cell culture studies, it was shown, and we also discussed it, that this oxidized LDL cholesterol has a much higher and greater effect on the first step towards atherosclerosis, endothelial dysfunction, than LDL alone. So it might be that in the absence of inflammation, and inflammation is one of several drivers to bring LDL to oxidized LDL, and HDL might be positive, it might prevent this change. So we know why HDL may have a protective factor. So in the absence of other factors that cause endothelial dysfunction, only having an elevated LDL that is not oxidized may not need to plaque formation. This could be that there are other factors that may be the strong initiators, and then of course LDL may work. But in the absence of all the other factors, maybe like your young athlete, the LDL alone may not be that difficult, important. And there is evidence from studies. This is a study, 3 randomized controlled trials combined. These were studies on nutrition, and all the patients in these studies were on contemporary statins. Age 64 years, 33% primary prevention. And the interesting point was that when you compare these and you look at high sensitivity CRP and LDL cholesterol, and you have the different quintiles, then cardiovascular death, and this is similar for all-cause death, was driven only by inflammation, by higher levels of high-sensitive CRP. So you see, even in the highest quartile for LDL, more than 2.6, there is a slight increase in cardiovascular death, but up until this, no signal from higher LDL levels, all the same, but signals from inflammation. And if you group it here, if you have an LDL lower 70 or higher 70, if you have low inflammation, no increased risk for cardiovascular death or all-cause death. On the other hand, if you have a high CRP, then you have this risk. And then, of course, there is Paul Ridkers. And then, of course, Paul Ridkers tells us the story that now, where we have identified inflammation, we should treat it with drugs. To be honest, I really do not understand this concept, because is inflammation a disease? Or is inflammation just a smoke alarm? I mean, inflammation is not really a disease. Please keep in mind now, interleukin 18, interleukin 1 beta, and interleukin 6. They are elevated and they lead to high sensitive CRP. But let's start with smoking. In the CANTOS trial, in the CORCOT trial, active smokers, 24%, 30%. Smoking increases interleukin 8, interleukin 6, and interleukin 1 beta. Of course, in a broader scale, when we take the exposome perspective, air pollution causes systemic inflammation and endothelial dysfunction. Let's go for obesity and type 2 diabetes. CANTOS trial, 50% obese, 40% diabetes. CORCOT trial, 36% obese, 20% diabetes. And you see in obesity, you have inconclusive with this one, decreased but increased. You have the interleukin 18, you have interleukin 6, you have here in type 2 diabetes, interleukin 1 beta, interleukin 2, high CRP. So they are elevated just because you are obese or you have this. And then, of course, it's about our nutrition. It's about ultra-processed food that not only lead to obesity, but that, of course, increase the pro-inflammatory bacteria in the microbiome and also the inflammation. So this inflammation signals is not a disease itself, but it just shows that there's something going on that can be due to obesity, that can be due to smoking, that can be due to nutrition. But also, and this is a very seminal study showing for the first time that chronic stress measured by amygdala activity in the brain is associated with cardiovascular disease. And the authors convincingly showed two pathways via bone marrow activity, arterial inflammation to cardiovascular disease, or direct arterial inflammation and cardiovascular disease. You see here the amygdala in a low activity and here in a high activity patient. You see here a signal for vascular inflammation, and you see here the bone marrow activity. So also chronic stress induces inflammation. And there's now good literature showing that chronic stress not only induces inflammation, but also endothelial dysfunction, altogether contributing to the development of atherosclerosis. And when we go on, this is so-called sleep. It's the same story. If you have bad sleep quality, if you have too few, too high sleep, then there is an inflammatory response, and you see the same levels that we've seen, CRP, interleukin-6, CR increase. So there are a lot of lifestyle factors that change, that increase inflammation. Okay, I come from rehabilitation, so the question is, what about exercise? And of course, I can tell you that in theory, exercise can limit obesity, counters diabetes, strengthens the immune system, improves circulation, you name it. So exercise is a polypill, we all know. An important point in the discussion on lipids is that it does not really improve the lipid profile. So to date, it's the only intervention that increase HDL without medication. You get it for free without side effects. But if you just look at the absolute lowering of LDL cholesterol, it's only 0.2. The question is, so what? You do not have to lower your LDL with exercise, because what you do with exercise, and this is the important point, you modify the starting point. And exercise is really one of the most important interventions to maintain endothelial function or to improve endothelial function. And this is really done by sheer stress. So you cannot achieve this with a pill. You cannot achieve this as rest. You have to sweat in any way. But because if you increase the sheer stress, either by endurance or by strength activities, you really have the positive effects of NO synthesis, vasodilatation, more NO bioavailability, reduced inflammation, and so on. So you really start at the beginning, you prevent endothelial dysfunction. So therefore, it's not so important that the reduction of LDL is not there. Of course, data on physical activity, sedentary behavior, and mortality, they are not very convincing because you cannot do randomized controlled trials in this field. It's very difficult. This is the latest umbrella review, 48 meta-analysis, 25 are rated quite well. But you see the highest level of evidence is that at least it is suggestive that physical activity reduces all-cause mortality, that sedentary behavior increases all-cause mortality, but of course it's highly plausible. Okay, so my conclusion, my take-home message is, of course, we do not have to argue LDL plays one violin in the orchestra, but good music needs the whole orchestra and proper timing. Because I also showed this last time, the Life Crucial 9, nicely summarizing what is important for prevention. And you all know you only have some time for the patient to counsel him or her. So when you have to split your time in counseling your patient, you should, of course, speak a little bit about cholesterol, but you have a lot of other topics to address. And I think this is very important that you keep the proper balance, and not just because there are 1,000 drugs out there for lipids, you focus on the lipids. But I think when you spend some time, definitely counsel on blood pressure monitoring. It's a measurement. There's currently a nice case in the New England Journal of Medicine on blood pressure just this week. And I think it highlights again how difficult it is to reduce the blood pressure. And this is definitely more bang for the buck if you lower the blood pressure. But nevertheless, there's a lot more. And my last slide is the orchestra needs musicians from society, not only from the doctor's office. This is a recent publication about tobacco control in Europe. And you see Switzerland, we are red. we have the second last place here. So tobacco control is nearly absent in Switzerland compared to other countries in Europe. And I highlighted how important smoking is for endothelial function. So, I mean, we can do a lot in the doctor's office if we do not fix this. I mean, this is a large contributor to atherosclerosis. And I think it's always important to see not only the personalized approach, but also the population approach. But there we doctors, we have to do advocacy and nothing else. So grazie mille for your attention.
Thank you very much for this very, very interesting talk. We have already 2 questions from the audience in digital. Dottoressa Antonella Veronesi asked from, in daily clinical practice, how do you envision integrating high sensitivity CRP and inflammatory profiling into cardiovascular risk stratification behind traditional score 2 assessment?
So basically, we do it in every patient. It's not an expensive parameter. When we do a blood profile prior, post rehabilitation, or in different populations, we always measure high sensitive CRP. And I think particularly in these cases like the athlete, I think having the Lp(a) and having the high sensitive CRP, and then of course you are right with for example calcium in athletes who do high endurance sports, but this calcium may be particular in that subgroup of athletes that might have endothelial dysfunction. So I think it's very good if you really try to have a personalized approach, if you have shared decision making, because then you can show the individual the whole palette. And I mean, personally, if I would be 36, if I would have a low CRP, low Lp(a), no calcium, no soft plugs, I wouldn't take a statin at the age of 36. I would just control it. But this other may say, okay, I feel more safe to do it. But I think high sensitive CRP is very good for personal shared decision making.
And another question, are we moving from a cholesterol center and model toward an inflammatory center model of atherosclerosis?
Maybe Kostas can answer this better than me. At least I would say, in a way, yes.
Great question. Thank you. And thank you, Matthias, for the great presentation. I mean, I fully agree with the way that you framed it, Matthias, that it's not inflammation, but inflammatory response. So you need to have something that causes inflammation. So it's not something that comes out of nothing. This is why many people in the literature also have questioned the approach of targeting the latest stage of a cascade that's behind it. I don't think that we need to switch from one model to the other. I think we are understanding better now that it's a very complex interplay. It's correct that we are not fixed to a single part of this very complicated pathway, that we are not trying to address only one of the many parameters that lead to atherosclerosis or its complications, and that we try to address the risk profile more holistically. In this context, if not necessarily atherosclerosis per se, then treat anything that would lead to atherosclerosis. Simple measures that don't need any expensive drugs, for example, quit smoking or start exercising, right? And yes, in terms of pathophysiology, I think that it has been many years that we understand how inflammation and lipid disorders go in tandem in accelerating the progress of atherosclerosis.
Thank you. I have a question about lipoprotein (A). Do you think that we have a wrong target? In our guidelines, our target is LDL cholesterol, but you show us that, and we know that lipoprotein (A) is more atherogenic. Do you think that in future the new targets will be the lipoprotein (A)?
I mean, it's definitely interesting, and how Kostas framed it. Currently, it's we cannot treat it, but at least in patients or in individuals with high lipoprotein little a, we can try to do optimized treatment of other risk factors. And again, it's all about shared decision making. So if somebody has a high LP little a and is a smoker, this is another very good reason to stop smoking soon. And of course, I mean, when we have drugs that can reduce it, then we have to see the trial, what is the outcome. But I think it's also all about the outcome effect. So how many patients do I have to treat to really save one life or reduce one myocardial infarction? I think the effect size is very important, and we are more and more exposed in studies to complex statistical models, hierarchical models that in the end shows that something is significant. But I think we also have to move in a way what is cost effective and what is also really what makes an impact. And it has to be shown what can be achieved.
There is another question from the audience remotely connected from Dr. Mauro Capoferri. He asking about sensitivity CRP. So the statement is it is a highly variable depending on some factors that can change quickly: bad nights, subclinical inflammation, stressful days. Are there standardized conditions to measure it?
Yeah, I think this is a very, very important message. I can share a short story. For me, we had the European Society of Preventive Cardiology meeting. There was the way to check everything. I went out for a short jogging in the afternoon, a little bit more intensity, and my high sensitivity CRP was a little bit elevated, by otherwise was very low. So I think it's very important to put it in the context when you had an infection or something else. You really have to ask the patient that he or she is in a very stable situation, and or if it's elevated, I mean, you have to look for reasons, and sometimes we repeat it to see it. But definitely there are other causes than vascular inflammation. Maybe Kostas, you want to comment on?
No, fully agree. Just to put it also in the context of blood pressure, for example, we know how variable that is, of course, how important it is to correctly measure it. This is what we do clinically, what we recommend doing. And this is what has raised some questions about many trials. How can you represent the blood pressure status of a person by a single measurement, especially in older trials, which could be under any condition, correct or incorrect, and then show any effect of a drug, any relation with subsequent outcomes? It needs to be standardized, and we need to keep into account the variation of all these factors.
What about LPA? It's just enough to measure it once and that's it, or maybe it's worth to remeasure over time?
Maybe Kostas can answer. I've heard that there might be some variability in LP(a). So usually it's tested once, and maybe in women after menopause a second time. But personally, and I think also there, Kostas and I are quite close, it's not about the absolute numbers. So whether it's 48 or 53, it's more to integrate LP(a) in the overall context. And I think when something's changed, I mean, you can measure it a second time. But I did it in some patients, and it was usually always in quite the same range. But Kostas, can you comment on variability?
I mean, there can be variations, small or modest variations, but they're usually not meaningful. As you said, if you come from 20 to 25 or 30, it doesn't change really your category or the context. Even if you have an increase because of a statin, a small reduction because of a PCSK9, it has to do with in which range you belong. And also, again, very important, the overall context, not just LP, not just any single parameter per se, but the whole picture.
And maybe just an additional comment on this. So I hope that further research will support this. I'm really a friend, particularly in personalized medicine, treating the phenotype and not the risk factors. So I think when you do a cardiac CT with angiogram, it has a very low radiation, and it has quite a prediction now for 10 to 15 years. So if you do it once or two times in a life of patients at risk, then you really you reduce downstream costs. And to find a good decision on whom you recommend a CT, I think there Lp(a), high sensitive CRP, and the history can really contribute. So for me, it's more gatekeeper towards imaging, and then I feel much better to treat the phenotype and not the risk factor.
Thank you. So thank you very much for this great talk. It's not really a lipid question, but since you mentioned this a lot, and I was wondering about the smoking cessation, about stopping smoking. I have the impression I'm seeing more and more younger people who are smoking these e-cigarettes, and I was wondering what's the difference between the normal cigarette and an e-cigarette in terms of risk for cardiovascular risk.
I mean, the good thing is now we've learned from Kennedy in the US and from the US Health Department that smoking is not dangerous anymore. So you can use nicotine, and maybe this will change the whole literature. So maybe we do not have to smoking cessation at all. I mean, the point is that there is really also this depends on what you like. Some say you can use e-cigarettes, for example, to stop smoking, to use it for a certain period of time, like you use nicotine patches or so. Others say, okay, there are other ingredients in them, and they are at least ex-atherogenic, like normal cigarettes. So I'm not an expert in this field. So usually, what we do, we really try to convince our patients in rehabilitation to stop smoking. And there's nice literature that after a myocardial infarction, for example, people are sensitized to do so. Interestingly, when we do rehabilitation, we can convince patients very easy to stop smoking for maybe 4 weeks prior to an operation. And after this time, they do not have the craving anymore. So when they then enter the rehabilitation program thereafter, they say, okay, it's not so difficult for me to stop smoking. So it works when you do it in a proper way. Sometimes you need a psychologist, and it's sometimes a little bit tricky. But of course, you have to invest time. And if this ways leads over e-cigarettes for a certain period of time, for me, it's okay. But the goal should be really stop smoking.
Thank you very much.
We are a little bit over time. So I have a very last request. I don't know if you can both reply. So during the last ESC Congress, I was enrolled in a study. So I was one of the lucky one after a very, very long line to get a complete blood panel testing, including all the parameters that you discussed this afternoon. So my question to you is, can you give some insight on the cardiovascular risk profile among the cardiology community, or you are not really involved in such study?
At least I know that it's been done, and it should be published someday, or has it already been published, Costa? But I mean, we have the same as the ESC preventive cardiology, and I also was a lucky one, and my high sensitive CRP was a little bit elevated those days. But they told us that all the data that they gather during the conferences, they will put in a study and they will publish, so healthcare professionals attending cardiology conferences, what is their risk profile. So I think there will be a publication, but I do not know who is on lead there. Maybe Tom Löscher is involved. You may ask him.
I really look forward for the publication, but at least the awareness among the cardiology community is extremely high, because it was really hours of waiting list to get such panels.
I mean, my only comment is that we don't know the results about the biomarkers, but I think that as an attitude, I think it's a good message that physicians, not just cardiologists, are aware and convinced about healthy lifestyles. They discuss it with their patients, but they also implement it. I think when I was a medical student, I had many professors who were in their office smoking. You don't see this currently. I think it's slowly becoming a habit that we need to take care of our lifestyle before embarking on complicated tests or drugs or whatever. So I think we're becoming more mature as a medical community, at least in a healthy CV prevention approach.
Perfetto, grazie mille a tutti. Voglio ringraziare il mio comoderatore, professor Conte, i 3 meravigliosi speakers di oggi, le persone presenti qua e quelle connesse in remoto, e ovviamente i nostri sponsor che permettono la realizzazione di questi pomeriggi del Cardiocentro. E vi do appuntamento al mese prossimo. C'è anche un aperitivo al nuovo baricentro al 5º piano, dove siete tutti invitati, ovviamente chi presente. Alla prossima.